This video is a surgical demonstration of management of a macular hole, and this is the hole as we can see, and it's a sizable hole, something like 200 microns. And this is the OCT, which shows a hole with the operculum, and it has a favorable macular hole index, that is the height is higher than the base. And this at this moment the retinal surface has been stained using brilliant blue dye, and we are trying to create a ILM flap using pinch and peel technique. So the forceps is used just directly to pinch the surface of the ILM and create a small flap. And this is in contrast to technique used by using flex venous loop or a Tano membrane scraper, where you shear the surface of the retina to elevate a flap. This is more efficient, and I have found that it is not causing any further damage to the retina. Once you have an area of retina where you can have a border of ILM defined, then you simply grab hold of one edge of the border and start peeling it towards the hole. Now it's a good practice to peel the ILM centripetally. That is, you proceed from the periphery up to the center of the hole, and this will help in also pushing the tissue centripetally, which is what we want. So it will aid in closure of the hole right on the table. So once you have reached one edge, then you proceed on to the other side, and then you start peeling from there, so that intentionally the peel is always towards the center. And this effort or this strategy has to be contained till you have peeled the membrane all around the hole. This is not complete yet, so one has to proceed to peel the ILM up to the arcades, and then this can be done in a fashion where you can peel in any direction, and because now the ILM is not attached to the edge of the hole, so it will not cause any further enlargement of the hole. One thing is remarkable here that I have seen that, as we can see, it's a large flap being created here, and this is attributable to the nature of the brilliant blue dye, which not only cleaves or somehow weakens the attachment of ILM to the underlying retina, but it also makes the ILM more resilient to tear. And this is what I have seen, and at times if you find that your peels are getting patchy and small, you can simply go ahead and stain the surface again with brilliant blue dye for a longer duration, and you will find that now the ILM is more resilient to tear, and that will help you in creating a larger flap and proceeding faster with the peels, and also atraumatic, because then you have to pinch the ILM less frequently. Now one thing is different from my technique, and that is that I don't use C3F8 gas or SF6 gas, and I found that even air works well, and it has added advantage that it is free. And one more thing is that it clears off in about 15 days completely, and maybe about a week it takes to clear off, so that your macular area is visible to you and you can capture a photograph of the retina and also do a OCT. Here we can see that we have reached on the nasal side of the hole and up to the optic disc, and this seems adequate peel. Now once the peel has been done, I usually resort to some kind of mechanical surface massaging of the whole border, so as to pull the tissue towards the center of the hole, and this has to be done very gradually, and this is supposed to break any surface tangential traction which is still prevailing at the border of the hole, because we have not been able to manipulate that area once we were handling the ILM on the surface. And these two things combined, that is the ILM peel and this massage, usually results in a very kind closure of the hole. Once 1 week has passed, this is the photograph where we can see upper part having a bubble, and this is the pre-op photograph of the hole, which has converted into a situation where there is hardly any detectable defect in the retina. This is the pre-op OCT where we had seen that there was a hole with the operculum, and now this is the status of this hole, which is an excellent closure with all the layers of retina realigning to each other. Thank you.